There we go. Thank you. So welcome again. Here are some quick reminders. This is just Zoom housekeeping. So as Rebecca just mentioned, all participants will be muted for the duration of the event because this is a webinar. So if you would like to ask a question, please type it in the chat. One of our staff members will answer it or direct the question to one of the speakers during the Q&A portion of the evening. We will have plenty of time for questions towards the end of the meeting. And if we don't get to some of the questions, we'll be sending a follow-up email where we could address some of those as well. You also won't be able to see each other. You can see us, the panelists. That is just a feature of the webinar. We wish we could have everybody on camera, but we're expecting around 250 people today. So you can imagine how that can be challenging. We have also enabled closed captioning, which means that you should see subtitles at the bottom of your screen. If you can't see them or if you would like to turn them off, please go to the bottom of your screen, click the button labeled CC and choose to enable or disable closed captioning. And if you're having any issues with that, you can also put it in the chat and one of our staff members will try to help. As I mentioned before, this meeting will be recorded so that it can be shared with newsletter subscribers and audience members sometime next week. And we will also include links to all the resources mentioned today in this email. So please don't worry about clicking on everything or writing everything down. You'll get that email with those links. So before we get started, we would like to invite you to join us on a land acknowledgement. This is something that we do before all of our meetings. And I'm just going to read from this and ask you to join us. So we'd like to start with an acknowledgement of the traditional and stolen lands that we reside on. End of Life Washington maintains a statewide presence, which means that we live, support clients, and work to educate individuals in the ancestral lands of 29 tribal nations. In addition, End of Life Washington recognizes the Duwamish, Wanapum, and Chinook tribes working for recognition by the US federal government and which have a long history in present-day Washington. To acknowledge this land is to recognize the history of physical and cultural genocide and settler colonialism, which continues to displace and shorten the life expectancy of Indigenous people today. As we coexist in this era and in this work, we ask you to join us in a moment of reflection on how we benefit from occupying Indigenous lands, how we can educate ourselves and take action about the state-sanctioned violence and other struggles that Indigenous peoples face, and which we may have the privilege to be unaware of, and how this violence creates barriers for Indigenous and other underrepresented populations who are seeking access to death care. So we ask you to just take a few seconds to reflect on this, and then we'll continue. Okay, I would also like to just give you a glimpse of the agenda. So we already went over our welcome. Next, we'll hear from End of Life Washington's board president, our co-executive directors, and our development director. And then we'll launch into a very exciting panel discussion with representatives from End of Life Choices New Mexico, Patient Choices Vermont, and End of Life Options Colorado. And then you'll have me back from some closing remarks. So we really hope that you stay until the very end, but of course we understand if you need to pop off sooner, that's perfectly fine as well. Okay, and with that, I am going to hand it over to Eileen Ravella, our board president, for her remarks.
Thank you, Daniela. I so appreciate having the opportunity to just speak just for a few minutes, welcoming everyone to this great forum. Just a little bit about me. I am a PA, have been a practicing PA for over 40 years. I'm also a provider and a prescriber for End of Life Washington. So I'm excited to have that role where I'm able to be at the bedside of our clients who choose this great option when appropriate. So I want to thank you all for being here. We've got a lot to talk about tonight. I am always available through End of Life Washington if you want to contact me. Yes, thank you, Rebecca, for pointing out PA is a physician assistant. My goal joining End of Life Washington is to educate PAs, NPs, and providers about how to have conversations about this crucial time in people's lives. So thank you so much, everyone, for being here.
Thank you, Eileen. That's wonderful. And with that, I am going to pass it over to our co-executive directors, Casa Sutherland and Alex Rams.
Hi, everyone. Thank you so much for being here with us and for your patience with our tech issues. You might have heard me say there's always something, and it's a different thing every time. So we get to solve lots of different fun problems together. I'm Alex. I'm one of the co-executive directors for End of Life Washington. We've seen sweeping changes in our country this year that have had deep and lasting effects on our people and on our future. Across the world, millions of humans are being deprived of their basic rights to food, shelter, and dignity. As we get to come together tonight and be a force for reducing suffering in our small corner of the world, we do this from a place of relative privilege and comfort. I'd like to ask you to take a moment of silence with me to reflect on the rights and privileges we have, the ones we don't, and the ones we're fighting for both here and elsewhere. Let's be quiet together for about 20 seconds. I'd like to briefly thank both of my children for choosing those 20 seconds to not scream. So you didn't get any extra background noise. Here in Washington, we're seeing more hospices provide more medical aid and dying services to a point where our volunteers don't need to be as involved at the bedside. We're also seeing more providers get the training they need to support their patients in choosing medical aid and dying when that's their wish. At the same time, the need for our services continues to increase every year. More and more people are learning about the option of medical aid in dying and voluntary stopping eating and drinking. I'm going to call them MAID and VSAID to save some time, and wanting to use those choices. We continue to adapt to meet that need and collaborate with providers and hospices to ensure that every eligible person in the state who wishes to use MAID or VSAID has that option. Here at End of Life Washington, we're building on and scaling our work as we never have before. Earlier this year, we released our hospice map. This is an online interactive map that shows people their local hospices and lets them choose hospices that align with their wishes and values. You might see a link to the hospice map showing up in the chat, or hopefully you will soon. I definitely invite you to go check it out when you have a chance. This map has catalyzed powerful conversations across the death care sector about how hospices can and cannot participate in medical aid in dying, and is gradually shifting the landscape of medical aid in dying and voluntary stopping and eating care, stopping eating and drinking care across the state. Over the next year, we plan to continue to maintain and scale direct services so we can support every person in the state who wants access to MAID or VSAID, to grow knowledge of end-of-life choices, to strengthen our organization, and to continue advocating for choice at the end of life. Financially, as an organization, we are shoring up our infrastructure in anticipation of hard times ahead. Right now, we have 1 full year's worth of expenses in reserve in the event that we experience a sudden drop in donations. We have a very conservative investment and reserve plan in place. And our goal is to ensure that we can continue being here for the long haul, to ensure that we're supporting Washingtonians' rights at the end of life for decades to come. One of the ways you can help us with this work is by supporting our efforts to recruit new board members. We're actively looking for new board members. Board members spend between 4 and 12 hours per month volunteering with us as champions of the organization. Serving on End of Life Washington's board is a way to lend your unique expertise and perspective to this work. If you're interested or know someone who might be, please apply. There's going to be an application link showing up in the chat, or reach out to us to learn more. And the contact information for me and Casa is going to be in the chat as well. I'm now going to pass it on to Casa to tell you a little bit more. Thank you.
Thank you, Alex. Thank you all for being here tonight and for sharing space with us this evening. It means a great deal. I am Cassandra, one of End of Life Washington's co-executive directors, and it's an honor to be here. Thank you for your ongoing trust and support of this organization over the years. I am really excited for tonight's panel discussion, and so I'm going to keep my remarks brief so we can get to that conversation. However, in trying to figure out what to say with you all in these few moments really just simply is not enough time. And so my hope over this next year is that we find some more time to spend together. Both Alex and I welcome your phone calls, emails, ask to go to coffee or a meal. We really hope you will reach out to us, and we really hope that you will join us at an event in this upcoming year. We're enjoying spending time with and among the End of Life Washington community. It's inspiring the depth of passion and care that we all share. 2 months ago, we were in Spokane at our Community Appreciation Night, and 50 relative strangers were in a room abuzz talking about choice and autonomy and death care and making new acquaintances and friends. And it's those moments that really remind us of our shared passion and care to this work and the ways in which we are all connected. So thank you again. I am really proud of where we are as an organization. We're strong and stable amongst so many uncertainties, and we're continuing to serve our state with excellent care. Alex shared that we are busier than ever. We have brought on over 30 new volunteers in the last few months to continue to deliver client services and education, and we are trending to support more than 1,300 clients this calendar year alone. We are hiring for a new position, a volunteer manager position, to support the organization's sustainability and recruit and train volunteers so that we can continue to have our service be at the heart of what we do. We really can't do this without our volunteers. We know we're not an emergency service, but our volunteers are mobilizing, sometimes within mere hours, to go be bedside and support people take MAID medications or be in support of VSEN. End of Life Washington as an organization continues to deepen our commitment to equity, inclusion, diversity, and belonging, and grow our skill set here. What is exciting is that we are finding that people are seeking us out as an organization for that reason alone and for that commitment. They're excited to join us in this work and even more excited to provide excellent client-centered care to everyone who reaches out to the organization. Our goal this year was to reach 34 Washingtonians with education. That was a fiscal year goal, and we're not even halfway through the fiscal year, and we're far exceeding that with over more than halfway to reaching that. We've given over 33 presentations to over 1,500 people here in our state. The team is educating in every opportunity they get, from universities to hospices to public libraries, and more often than not, these presentations are happening in person again. We know that the lack of awareness and knowledge of end-of-life options continues to be a major barrier that people experience in knowing what's available to them. And we continue to hope to lower those barriers by educating and spreading the knowledge of the choices that people have in our state. And this happens through our educational volunteers and our staff team who work tirelessly to make sure people know what their options are. Finally, in advocacy, we continue to pursue initiatives that uphold autonomy and choice. One major challenge we are still tackling is that the Department of Health's decision to defund the reporting and oversight of the Deaths with Dignity Act. Regardless of how you feel about the act itself, oversight is crucial to maintain the safeguards outlined in the statute. We will work with the department to restore their mandated commitment to that oversight and reporting. And we will continue our efforts to make Washington the best state to die in and ensure that this organization is available to anyone who needs our support and services for years to come. As I wrap up, I have an ask of you all. Earlier this year, Petter, a social worker at Fred Hutch, nominated End of Life Washington as a community organization in the BECU People Helping People Awards. We stand the chance to win $40,000 by being the most voted on organization. We're going to take 2 minutes to watch this just phenomenal video of Petter talking about what end-of-life Washington means to him. And then we're going to ask you, if you can, for 30 seconds of your time to vote for us in this video. So Daniela, you want to go ahead and share the video?
I can certainly do that. Okay.
My name is Petter, and I nominated End of Life Washington. End of Life Washington is a nonprofit organization that started in the late 80s to shed more light on end-of-life options. And they do that through education, advocacy work, making sure that patients have access to medical aid in dying, death with dignity, and through volunteers who come to people's homes if the patients choose to provide support through compassionate, kind, and wise way. In 2024, End of Life Washington supported a little over 1,000 patients. And if I think about that number, I can also imagine, the many family members that they touched. And they are able to provide all services absolutely free of charge. What I do is an oncology social worker. I have the extreme privilege to actually walk alongside of patients and their caregivers, family members, from the time of diagnosis through their treatment. And oftentimes, that also includes talking to them about death and end-of-life options. When I see patients who have just been diagnosed with cancer or just started treatment, they oftentimes tell me that they have absolutely no idea what to do. We culturally don't do well around aging and having open conversations about advanced care planning and death. And so having somebody like End of Life Washington and their volunteers makes all the difference. End of Life Washington volunteers are this community and come from this community. I cannot actually imagine doing my job as a social worker without having them in the community helping people and making sure that all of us have access to these end-of-life options and making sure that all of us have access to dignified death.
Okay. Thank you, everybody. And we are going to put that link in the chat again. And thank you to everybody in the chat who's voting. Casa, do you have anything else you would like to add?
No, I'm going to pass it over to Krista.
Thank you.
Hi, good evening, everyone. Thanks so much for being here, and thanks to Casa and Alex. I want to thank everyone for voting for us for the BECU Award. It's really quick and easy to vote, and the voting ends tomorrow at 5 p.m. So if you haven't voted yet, please do. We would really appreciate it. My name is Krista, and I'm the Development and Communications Director for End of Life Washington. I wanted to say a quick thank you to the 25 people who donated when registering to attend for our annual meeting tonight, raising over $1,000. So thank you so much. As Alex and Casa had mentioned, more people are using our support services and asking us to come in and talk about end-of-life options. End of Life Washington is the only organization in Washington State that provides this type of service, and all at no cost to clients. 79% of our funding comes from individuals and people like you and me who care about choice at the end of life and assuring that every Washingtonian has the support they need during this very tender time. We're gearing up for our annual end of year campaign, which starts at Giving Tuesday, and that's December 2nd. and we would love your support. We're going to drop a link to our donate page in the chat now. And I wanted to say that any amount is appreciated. And we really, I wanted to thank you for your support this evening. And I'm really excited about our panelists. So I'm going to turn it over back to Daniela, and have a good evening.
Thank you, Krista. Yeah, we are going to move on to our panel discussion, and Casa is going to lead there. So take it away, Casa.
Awesome. I am very, very excited about this. So thank you so much to our guest panelists for being here. I have the pleasure of introducing and facilitating tonight's panel section of our annual meeting. Today, we are joined with Amy Bruce from Vermont, Barbara Morris from Colorado, and Julia Bergen from New Mexico, all of whom are joining us later than West Coast time. So huge shout out to them, especially Amy over there on East Coast, and Laura, who I've made a late evening. So thank you for the time this evening. I met the majority of these leaders in New York a year ago, almost to the day. Amy wasn't in New York, but she had just been hired by Patient Choices Vermont. So it kind of felt like we got to know her because we heard a lot about her actually in that space in the New York time. We were all in New York because the Completed Life Initiative brought state leaders, all from states that had medical aid and dying laws, out for a few days of sharing and collaboration. It had been the first time ever that we were all in a shared space together and have built relationships from that space that have continued this entire year in monthly conversations, talking about what's going on in our different landscapes and how we're handling them. So I'm excited to bring some of that into Washington today. It feels like the connection between local and national is more important than ever as we are working together in shared vision and goals. So I'm going to start with just each panelist introducing themselves, a little bit of who you are and why you do this work, and then also introducing your organization to us and telling us a little bit about what each of your organizations do in your respective states. After our introductions, we'll talk a little bit about how our medical aid and dying laws differ between the states, and then we'll dig in with some questions from there. But Amy, will you start with introductions?
Sure. Hello, everybody. Thank you so much for including me in your meeting tonight. It's really great to be with all of you. And yeah, I've had the pleasure of getting to know the leaders across the country in the MAID state organizations through our monthly meetings with the Completed Life Initiatives, the collective that we're a part of. And for me, being new to Patient Choices Vermont, it's been really a wonderful support system. Prior to coming here to Vermont, I've worked in hospice and palliative care for about 20 years. My background is really in grassroots community health education. And then I moved into this space, like many of us, through personal experience with family members, being under hospice care and going through cancer journeys and realizing how much support patients and families need when they enter that, that cancer planet and everything that comes with it. I was working in palliative care in Northern California in 2015 and 16 when the California End of Life Options Act passed. And so I've worked in and around this topic for a number of years, supporting both patients and families and provider teams in really coming to grips with what a new type of end-of-life care means. And so was so honored when I was invited to join Patient Choices Vermont, one of the organizations that's a real pioneer in this work. Patient Choices Vermont is the medical aid and dying organization here in our state. Again, like End of Life Options Washington, we're the only organization that focuses on this work here. The group started in 2002 with a couple that decided they were going to spend some of their retirement time working to get medical aid and dying legal in Vermont. It took them 11 years, but they gathered an incredible group of people along the way. So in 2013, the Vermont legislature passed Act 39, our medical and dying law. The organization then realized that having a law on the books was not enough to ensure access. So we're still active today, providing all of the work that you all have described that you're doing in Washington, the education and the support. We're a very small nonprofit. I'm actually their very first executive director. So the original group of board members have been carrying the ball for many years, and I'm really just so honored to take the baton from them, to mix up my sports metaphors, and keep us going and growing. We have also now a part-time program manager, so a mighty staff of 2 with some very dedicated volunteers that are doing all of the day-to-day support of patients and families. And I think I'll probably talk more about those volunteers and the other people we work with that are on the ground a little later. So I think I'll call it good there. Thanks.
Thank you, Amy.
Mhm.
Barbara?
Hi, everyone. I'm going to add my thanks to End of Life Washington for inviting us. Of course, in Colorado, we consider you the pioneers and the people we learn from. So I feel humbled to be adding to this conversation, frankly. And of course, also enjoyed meeting everybody at the meeting. Hard to believe it was a year ago. So, Casa, you asked the question of why I'm in this work. I'm a geriatrician. I happen to now have the honor of being the president of End of Life Options Colorado, and I'll talk about that in just a minute. But some of you are aware of the spot of trouble I got into now 6 years ago. And so, ironically or not, or if you believe in coincidences or not, today happens to be the anniversary of the death of Neil Mahoney, who was the patient who actually led the way in my learning about what was going on in Colorado and our need to become more active in education and access for Coloradans. So I take a moment to remember Neil and all he contributed in terms of what ended up catapulting me into this work, frankly. So here I am. So the other anniversary is this month, End of Life Options Colorado celebrates our 3-year anniversary. So we're toddlers and we are learning every day about what Colorado needs. And so I'm very proud of our work to date. We are really focused on education and access for our state and have made some progress in making sure that Coloradans know what their choices are and that they're able to access them. But we have a long way to go, and we're going to learn from all of you. So thanks for having us.
Thank you, Barbara. And Julia? Oh, you're on mute.
Sorry. Good evening, everyone. I'm Julia Bergen. I'm the Director of End of Life Options, New Mexico. And we were established in 2021 following passage of the Elizabeth Whitefield End of Life Options Act, our medical aid in dying law. And I'll get to that in a second, I think. But I became the Executive Director of End of Life Options New Mexico 2.5 years ago. And really, because of my own personal experience and following a long career committed to education, equity, and social justice, and a lot of grassroots organizing, it just seemed like this mission and work was really the place I needed to land and focus on at this time in my life and career. And as I said, really influenced by personal experience, witnessing family members and friends go through really difficult, complicated end-of-life experiences. And while this has been a new domain for me and I don't have a medical background, I feel very passionate about what our organization and what this work has been able to do, really ensuring that people can make the decisions that they need to make for themselves based on their values and wishes. and hopefully well in advance of end of life, so that they're really engaging with not only their own beliefs, values, wishes, but with their loved ones, so that everybody has a clear understanding of what is wanted. But here in New Mexico, as I mentioned, our law was passed in 2021, and like Colorado and perhaps Vermont, we're relatively young organizations, but with us is an amazing community of committed, devoted volunteers who have been a part of the advocacy for decades, really working to the time when a law was drafted, crafted, and signed into law, and has really changed the landscape in New Mexico. But I thank Cassandra and all of you from EOLWA Washington for the opportunity to be here this evening and to share perspectives and thoughts about this really vital work, and how it's transforming the landscape within end-of-life care. So thank you.
Thank you, Julia. So one thing I want us to all take a moment to do and orient the crowd to who we are and how we work in different states is to talk a little bit about how each of our laws are similar and how they differ. So I'll start us off, and then we'll have Amy, Barbara, and Julia. Each of you can go through and talk a little bit about how your MAID law works in your respective states and what it looks like. So a lot of you are probably aware, our law was passed by voter initiative in 2008. It is called the Death with Dignity Act, something we try to step away from by using more terms like medical aid in dying. But here in Washington, a lot of people still refer to it as Death with Dignity or the Death with Dignity Act, because that's kind of baked into the culture of our state. It requires somebody to have capacity, to be terminally ill, to have a 6-month or less prognosis, to be 18 years of age, to be a resident of Washington State, and to self-administer the medical aid in dying medication. It also requires the assessment of 2 independent providers. These used to be physicians or DOs, but 2 years ago, this switched to open it up to ANRPs and PAs, which has drastically improved care in rural parts of our state, where the primary source of care is through ANRPs and PAs. We also have a waiting period that is 7 days. It used to be 15, but it's gone down to 7, but we do not have a waiver. So everybody has to wait at least 7 days between their first oral request and their second oral request. Amy, you want to tell us a little bit about Vermont's?
Sure, you made it easy. We almost match, like many states. So we, when Act 39, our medical aid and dying law was passed, it was modeled on the Oregon law and Washington law. So the same qualifications apply, with the exception that in Vermont, as of May of 2023, people no longer have to be residents of the state of Vermont. So we're one of 2 states, along with Oregon, who accept people from anywhere in the country to access medical aid in dying. And so we'll talk more about that. It's had a huge impact on medical aid in dying services in our state. The other difference is that in terms of the process, we still do have a 15-day waiting period. We did reduce, we got rid of the last 48 hours of that in 2022. So that was helpful, but we still require physicians as both prescribers and consulting physicians. So MD or DO, we're thinking about moving forward with expanding prescribing authority, but made a conscious decision to not do that in the current state of affairs. So.
Take it away, Barbara.
Oh, sorry. Thank you. I was going to say ditto, but not quite. So many of you know that our statute was passed also by voter initiative in 2016, went into effect in 2017. And as with many states, it's amazing to me how consistent these numbers are. This was one of the biggest margins of any voter initiative in Colorado history, actually, at just over, between 65 and 70%, which when you take a minute to think about that, is quite extraordinary. And this is kind of an aside, but I think it's important. There was recently a survey of some physicians in Colorado as to their information and understanding of the law and their support. And guess what? The numbers mirrored what the general population said in terms of support, which was quite reassuring to me, actually, as a physician. So our law has the same requirements as have been discussed in general about terminal illness, prognosis, decisional capacity. We do have a residency requirement, which we will talk about more later in terms of our thoughts about that. Just over a year ago, in August of 24, our governor signed an amendment to our law, which decreased our waiting period from the 2 weeks, 14 days to 7 days. And we do included in that amendment was a waiver so that the attending provider has the ability to waive the waiting period if it seems that the patient's suffering is extreme and that their death is imminent. And so we have been able to use that waiver now over the past year. That amendment also included the addition of advanced practice nurses as being able to play the role of either the attending provider or the consulting provider, and it can be both. So in other words, a patient can be served by nurse practitioners in both roles, which has been a big change for us. And we're working hard to try to increase education and availability because of some of the reasons that Casa mentioned about access in the rural parts of our state. Our law has an opt-out clause, which I didn't hear anybody else mention. I think other statutes have this. I think that has been actually problematic in Colorado. The clause was written in a way to change a little bit what went on in other states to say that health systems could opt out. And the way the law actually is written says if the patient wants to make use of the medication in their facility. So you can think about that a little bit. I would say that that clause has not been well implemented, is I guess the word I would put. So basically, in summary, our law is very similar to the other laws with a few of these differences, which I think have been advantageous for Coloradans.
Thank you, Barbara. Julia? You're on mute still. It's okay. It's just.
It's a habit. So, like the laws already described in New Mexico, the Elizabeth Whitefield End of Life Options Act, which was signed into law by our governor in April of 2021, has what we think of as strict qualifications in order for a person to utilize the medical aid in dying medication, be 18 years of age or older, have a terminal diagnosis from 2 providers, be mentally capable of making an informed decision, be a resident of New Mexico. And in addition, as you mentioned, Barbara, and I just want to allude to this, and we can talk about it a little bit more, in terms of providers who will or will not, or facilities that will or will not utilize or make available, they can opt out. But within our opt-out clause is the expectation that they will at least direct that person who's expressed interest in utilizing medical aid in dying to an entity where it is allowed, so that they're not being cut off entirely. Ours, again, has what we think of as robust protections, the determination of the patient's mental competency, and then, of course, the necessity for a referral to a mental health professional for evaluation if there is any question or concern about that client or patient's capacity. And then who is a qualified provider can be a physician, an osteopathic physician, a nurse licensed in advanced practice, or a PA physician assistant is also eligible. And our 48 hours, I think, is really unusual. within the larger landscape of access.
Thank you all. So we have a few questions in the chat for you all, but for those listening, I'm gonna save them for just a little bit later and then throw those out to the panelists as we go on. I'm really excited to jump into barriers and challenges and how you're facing them. But before we go into that territory, I would love you each to tell the audience just quickly what's going well, what's working really well for your organization in your state. What are some of the successes you're seeing? I don't know, Amy, if you want to jump in first.
Sure, I would say the end-of-life doula space is really thriving in Vermont. The University of Vermont has an end-of-life doula training program. I have met more end-of-life doulas in this little state than in all my time in California. It's really inspiring. People come to the work with such a wide variety of background, and they all have such tremendous hearts. They're embedded in their small towns, and they want to help. And we've been meeting more and more of them. So it's a huge benefit, because as we'll talk about, one of the challenges we have is meeting the needs of people coming from all over the country to Vermont. So they're a huge help with that. So I think that's going well. And it's also seems that the word is getting out, to retired or semi-retired physicians that maybe want to do a little bit of work here and there, that this is a practice that they can do without a great deal of overhead. They can actually maybe get back to practicing medicine the way they did in their early days, or the way that they would like to, which is just, being supportive of individuals and not having to answer to a big system. And so we're hearing from more and more physicians that would like to have small practices that focus on this end-of-life care. So those are positives.
Thanks, Amy. Barbara?
Yeah, thanks. So I think of this as the breaking up of the secret club is what I consider to be one of our successes. So, in 2016 and 17, I was a practicing geriatrician with a full ambulatory practice. I actually considered, when I heard about the statute, I was like, yeah, of course, this should be a tool in the toolbox. Frankly, I was rather naive, as we all know. But I think what I didn't realize was how secretive and worried clinicians were. And so at that time in 17 and 18, you really couldn't find someone who wanted to talk about aid in dying or the practice or helping patients. There was a lot of worry just about the work, and there was a lot of worry about being overwhelmed, like if someone found out you were doing the work. And what we've seen now in the past few years, particularly in the past 2 or 3 years, is the breaking up of that secrecy. We're very proud that on our website, we're actually able to list clinicians who are accepting patients. We have a very robust program at Denver Health, which reaches out actually all over the state and is helping hundreds of patients. So we are starting to see a big change in attitude and thoughtfulness about this. And I think that is real progress. For us, it culminated in our first conference. Amy joined us for that conference, where we had 130 people in a room, all willing to talk about aid in dying and other topics. Yeah, Amy's like, it was, I think the topics were wonderful. I'm very proud of that. But really, for me, more importantly, was the networking and finding out that we had colleagues across the state who we didn't know about, and they didn't know about us. And since then, we've been able to really pull a clinical group together to talk about issues. We've been able to refer to each other. We have lots of other health professionals doing the work. And I would say that our folks, our health professionals, not all of whom want to do the work are willing, but it's a lot more openness to engaging in that conversation. So for me, that culminated in some clinical work this week, where I was able to contact a nurse practitioner who knew the patient I was working with very well. And I was able to say, well, can I tell you about this? Could you be the consultant? And was thrilled to hear her say, yeah, I want to learn about that. And to have this patient's hospice nurse call me and say, yeah, no problem. I can be there. I will help. I'm going to be in the room. So I'm proud to say that I think the days of hospice organizations in Colorado discharging patients, not talking to patients, not giving information, I think most of that is over and in our past. We have a lot of work to do to integrate hospices, but I do think we're making a lot of progress.
Thank you, Barbara. And Julia?
I agree with both Amy and Barbara. I think our education work has really been stellar in the time that I've been with the organization. Our founders established a really interesting foundation when they created End of Life Options New Mexico. I refer to it as a three-legged stool. It's a clinician outreach committee, client support committee and team, and outreach and education team, public outreach and education. And each of those committee and teams of volunteers are working to really educate and inform as wide an audience of people across the world of clinicians and providers, people in the public, and students, social workers, healthcare, community healthcare workers, and others. And then also the work we do supporting families, and people find out about us through an open 24/7 warm line, and our dispatcher receives calls and inquiries from people looking for information across a fairly broad spectrum, not limited to medical aid and dying. So we've also expanded what our education and outreach looks like in the last couple of years, emphasizing advanced healthcare planning, supporting folks understanding why an advanced directive is a really important tool, and also borrowing from the really good work of the Conversation Project, encouraging folks to step into what is so often an awkward, difficult, confusing discussion around death and dying and one's thoughts about that. So in and through all of that education and outreach, we're really trying to ensure that more and more people are comfortable stepping into a conversation about what they think about death and dying, what their values are around that. And that leads them to then understanding within our state, our communities, what are the options that are available to them. And then we can do a deep dive into what is medical aid in dying, what is hospice, what is palliative care, what is VSED. But as we've broadened that access to information, we've seen an increasing number of people step up to participate at tabling events and presentations, and we work in partnership with state agencies and do a lot of outreach. So we're reaching more people, and that's really critical because we're a very rural, large state covering a lot of geographic area where there are a lot of limits to access to information and good care. So our folks are also able to reach more communities as a result of this expanding outreach and education work that we're doing.
Thank you. It's comforting somehow to know we're all in our respective states pursuing similar things. It feels nice. So thank you all. What barriers to accessing aid in dying are you witnessing in your state, and how are you working to address them?
So I'll go. We've got a pattern going here. Well, like I said, since Vermont accepts non-residents, when that residency requirement fell, the reports that I hear from the people that were working on the ground at the time was the demand was immediate and overwhelming to the organization. They had, I think there were just 2 board members answering calls and emails. They quickly went out and recruited a few more volunteers. So we now have 4, count them, 4 volunteers responding to all of these inquiries that we get. And we still, about 90%, 95% of our inquiries come from people in other states. And so it's really taken the focus of the organization to be able to respond to this. It's challenging for a state the size of Vermont, and like many places, of course, we're quite rural, and provider shortages at all levels. It'd be very challenging to find a PCP. I think we hear that everywhere. Urban, rural, it doesn't really seem to matter where you are, but it's really difficult. So for prescribers or physicians that may be interested in prescribing, prescribing for their own patients as those needs arise at kind of a natural pace is one thing, but to step into the space of prescribing for someone coming from New York or Florida or Texas, and they've never met this person, and they've got to do a lot of back and forth with records and all that. It's a really big ask. So we have had a shortage of prescribers, and unfortunately, unlike Barbara's account, we are still somewhat living in a land of strict confidentiality. I'm very happy to say that just in the last couple months, we have 3 prescribing physicians that we're able to connect patients to. This is a brand new move, and it's wonderful, but we have to be really careful that we don't overwhelm those folks. So helping people find a prescriber when they're coming from out of state is a huge challenge. Couple things we've done to meet that. Diana Barnard, who many of you may be familiar with, she's kind of, I feel like the mother of medical aid and dying, at least for me. One of our founding members has begun offering a drop-in physician only confidential physician meeting that anyone that's prescribing or is interested in prescribing or wants to learn can join this monthly meeting led by her and do a lot of peer support and learning. So that's it's a huge offering on her part, and I think going to be making a real difference. When we hear of someone that's interested, we now have a way to plug them into a network of peers, physicians. And then on the other side, for people that are coming from out of state, there's all the challenges of how do I get to Vermont? Where do I stay when I come? How do I find the support I need? And so we have a group of people that are not our organization's volunteers, but they're a group of independent practitioners. We call them wayfinders, and they are doulas, retired nurses, social workers who offer their services to support people primarily from out of state who want to come to Vermont to use medical aid and dying. And they support them from the very first question all the way through the day of ingestion if the person ends up coming to the state. So that network has grown. We just completed a much more robust training with them, and we've doubled the number of people that are now able to provide that, and we're spread out pretty much throughout the entire state. And so that's a way that we're helping meet that need. And it's as much a help, I think, for the prescribing physician as it is the patient and family, because like I said, the prescribers that work with families from out of state spend a lot of time, their staff spend a lot of time on the phone working through all these logistics. So if the prescriber knows that a wayfinder is there for that patient and family, it takes a lot of burden off of them, and so they're more willing to engage in the work. So it's been a really good thing.
Jamie,
Mm-hmm.
Barbara.
Thanks. Wow, a lot going on in Vermont, that's for sure. I think our challenges are a little bit different. We don't have as many people, coming to Colorado because we still have our residency requirement. We do have quite a bit of geographic access challenges. We have, Metro Denver area, and then we have the Western Slope, Grand Junction, and so forth. And in between, there's a lot of turf to cover. And so we're trying to work with our spreading network so that we don't get the kind of calls I was getting 2 years ago, like, there's nobody here, nobody will help me, what am I going to do? So, I mean, that's a call I don't want to get anymore. And we're making some progress with that by making sure we know who's in communities, who's available, how we can refer people. We also our clinicians continue to do quite a bit of virtual work, which I think can go well. But I always tell people my first choice is for you to have someone in your community who can take care of you. And so we're really working to connect the clinicians so they get the support that they need and can feel comfortable. Information is a real problem. I also hope never to get the phone call of, oh, my primary care physician told me it was illegal in Colorado. So, that's a goal, is to never have that conversation again. But we still have these gaps where I actually had someone a couple of weeks ago where the family said, oh, we were going to go to Oregon. Luckily, someone, got to them and said, no, you don't have to go to Oregon from Colorado. So we're working on those. I mentioned hospice integration. We are envious of all the progress, of course, in Washington, that with getting true hospice integration. We have many hospices in Colorado who will say, oh, we're so supportive of aid in dying. And that has many different meanings, as you know. It means they might be supportive of the patient, but they're actually not going to do anything to help. Or it means their clinician still needs to stay in the car when the patient's ingesting. We are making progress there, but it's a really big issue for us, and we're really working on that. And then I have a particular passion and interest in clinician education and coaching and mentoring. It's really important to me. And, what I always say to people is, look, we have clinicians who can't do the work. I did see something flash up in the chat about what I call restricted settings, because their institution is preventing, or because for many reasons. So there's a can't do it. Then we have the clinicians who just won't do it because of a variety of reasons. And then the group I'm after is those who really want to do the work, but haven't had the support and training that they need. And so we're trying to provide that whenever it's needed, like the nurse practitioner I was talking about from earlier today, because I believe that it's this just-in-time training that will eventually expand our ability to reach other places. I also saw a flash up in the chat about what we're doing about other populations. Big issue for us in Colorado. How do we reach our rural constituents? How do we reach those in demographics who have historically had a distrust of the medical system, the Latino population, the African American population? I wish I had answers for that. And if any of you do have good ideas for us, we would welcome them. We know it's a big issue, and we are certainly working on that. And then, though I hate to bring this up, we have some challenges going on because of some legal threats to our statute. And I'm sure many of you are aware of that and have read about that. So the most current lawsuit is by a group called United Spinal, and other groups that have joined in that lawsuit, which actually challenges the legality of our statute in its entirety. And so there's a lot going on about that, although the legal process is very lumbering and slow at the moment, which maybe in this situation is good. And one of the things we're focused on is making sure that Coloradans know that our law exists, that it's being challenged, but nothing has happened. Because, we all read like just the headline. And then I think people think, oh, something happened, the law doesn't exist anymore. So one of our big approaches at the moment is to make sure people understand what's going on and where we are with that lawsuit. I think residency is an issue for us as well. We would actually like to get rid of the residency requirement. And so that is work for the future.
Thank you, Barbara. A lot there and a lot of things I want to circle back to. But Julie, I want to give you a chance to also jump in.
A lot of similar barriers. Certainly, the more informed people are about our law, the better. And that's slow. Again, our Clinician Outreach Committee does a lot of outreach across sectors in our state to inform institutions as well as providers about what the law is. And to your comment, Barbara spends a lot of time mentoring and guiding folks so that their knowledge is increased, but also their comfort. When you understand what something really is about, I think it makes it perhaps more palatable. And that also leads to, I think, just the need to demystify what it is and really focus on ensuring that we're using language that tells what this law is and what it can do, and get away from what it's not, and the misuse of language about what it is, because that's a real barrier, I think, probably for all of us. And opposition thrives on the miscommunication about what medical aid in dying can do for folks. And I think again, more awareness about what this is in our rural state. One of the ways that we've been trying to, in some way, mitigate the barrier for folks who live far away, where there is very limited access to healthcare or healthcare information, is by working with community health workers whose model is to really be working in smaller communities. And like Colorado, there are often Latino, Hispanic communities or Native communities. We just presented at our state's Department of Health Community Health Workers Conference and had a really wonderful group of people in attendance who were from all over the state, from Pueblo communities, Navajo Nation, and more of those really isolated villages. So the more we can share this information, connect to people who are working in those smaller communities, I think the more we can address the diversity concern, as well as just expand people's awareness of the importance of this work.
Thank you. So one question we got asked in the chat was, which I intended to do, but I got excited by hearing from all of you, is to have Washington also answer some of these questions. So I want to just circle back to, I think one of our great successes as a state right now is exactly what you were saying, Barbara, is the integration of hospice into this work. We've seen over the last 2 years, especially with the change in legislation to make hospices be required to report what MAID services they can and cannot provide, combined with the work of Jess Kahn, the medical director, to reach out and educate each hospice. The hospice integration and the support of our hospice partners over the last 2 years has been incredible, and such a difference in our state. In terms of challenges, just one other thing I would add to what all of you have said, which I think Washington shares, minus the residency requirement. Amy, you are unique in Vermont in that way, is we have actually, I think, seen more clients come to us who have gotten less care in life. They maybe haven't had a steady PCP, haven't had the type of care that we'd want everyone to have in terms of healthcare. So they're coming to End of Life Washington with more challenging situations that need harder to find medical records, harder to track down past care to make a terminal determination. And I think that's an added challenge that we've also seen in Washington. All right, so there are some things that I want to sweep back to. And one thing that I just wanted, round robin real quick is, Barbara, you mentioned that people can do telehealth in Colorado. Julia and Amy, is telehealth also being provided for this care in both New Mexico and Vermont?
Yes.
It is legal to use telemedicine for this. That was part of the change in the law in 2022. But again, with out-of-state residents, it's risky for providers. It can be risky for providers to use telemedicine because all of these, the Vermont law covers activities in Vermont. And so if you cannot be certain that the patient is in Vermont when you're having a telemedicine visit, you're putting yourself at risk as a provider. And so again, with doulas or wayfinders that are in Vermont, if the prescriber has a relationship with them, they can kind of be vouching for, yes, we are here in the state. I think the people that we talk to, what I don't know and what's really interesting for our organization is, and where we want to focus with our outreach and education, is really getting a better sense of getting back to Vermonters, like what is happening on the ground for Vermonters in terms of access, because we honestly don't know. I think because we don't hear from them, we think everything is great. But then anecdotally, we hear, oh, people don't understand that they have this law, even though it's been a dozen years since it's been legal. So we have a lot of work to do, and we're doing that now on the ground and virtually, focusing on Vermonters and their prescribers and their long-term, primary care physicians to really make sure that we know what's going on. I think that there is likely a greater use of telemedicine in those relationships.
And I know we're all keeping an eye on the fact that the way that we're able to use telehealth to prescribe aid in dying medications is a COVID extension that is due to expire at the end of the year, and we're waiting to see what the DEA requirements are. There's a lot of talk about having a special category for hospice and palliative care that people can continue to do this work through, but I know that, you know, if depending what happens at the end of December, it could change a lot of how we are able to do this work in each of our states. Another rapid question that came up is people want to know, are your organizations offering your services for free? And also, what is the cost of the aid in dying medications in your state? Maybe you could do both of those. Barbara, I see you ready to go.
Well, I'm not laughing, but I am. You know, one of the conversations we have been having in Colorado a lot, particularly when we formed our organization, was kind of what model we wanted to use. And we were not prepared actually, or decided philosophically that we did not want to be providing, you know, bedside care, and we wanted to be networking to get patients their care, both with providers and other people, whether it's doulas or you know, their hospice organization or their physicians. And so that's what we've really been working on. I think this is a whole long conversation. We had some of it in June in Colorado about different models of care. I personally have a lot of concern, being a somewhat retired older physician, about putting all our eggs in the basket of retired clinicians, because I think that's not a long-term strategy for this work. And so integrating the work into both the work of hospice medical directors as well as the work of folks in practice, whatever that looks like, I think is really important. But it does raise the issue of financial concerns for patients, because we haven't talked about it, but I think as many people on this call would know, because of the federal act about preventing dollars from going to assisted suicide, there's a lot of prohibitions against bill. You know, Medicare and Medicaid will not pay for direct aid in dying services. And so that puts a damper on this idea that this should be part of, you know, regular practice and be reimbursed in that way. So I think there's a lot of work to be done there. In Colorado, medications, as everywhere, have become more and more expensive. Unlike California, our Colorado Medicaid will not pay for the medications. We have a broad kind of span between about maybe $400-500 to close to $1,000 for the medications. And for us as an organization, about it, not quite 2 years ago, we realized what a strain that would be on some of our clients. So we did, as an organization, develop a separate fund for patient assistance, specifically to help if medication was a barrier. A couple of the pharmacies that our clinicians work with regularly also will do some helping, some discounting. And so I think that that has been a very important aspect. And we do spend time talking with clients about what they need and how we can help if finances are going to be the big barrier.
Thank you, Barbara. Julia or Amy, you want to speak to charging for services and cost of medications in your state?
So we don't charge for any of our education support or any of the services we provide. It varies from physician to physician. There are private providers who charge a considerable amount to shepherd a patient through a medical aid in dying process. In New Mexico, the medication tends to average around $550. And like Colorado, we, in the very early stages of this organization, established a medication assistance fund, and that was to ensure equity in access, so folks that don't have the financial means aren't prohibited from utilizing it. And that's been something that we've really focused on in our own fundraising to ensure that we never have to turn away somebody making that request. But in the state of New Mexico, actually, New Mexico State Medicaid will cover the cost of the medication.
Wow.
Yeah, and it's been, yeah. So that's unusual, perhaps.
Great.
Yeah. And in Vermont, the medications currently cost about $750. Another rather precarious spot we are in is that we still only have one pharmacy that provides the medications. We have two other pharmacies who have said, by the end of the year, this fall, we're going to start. And I keep gently poking and prodding. And have you contacted your prescribers? You know it's, but still officially there's still only one. So thank goodness for them. And so Patient Choices Vermont does not charge for any of the education that we provide or any of the support that our volunteers provide over our helpline. That is limited to phone and email support. However, that's not any bedside support. And, you know, we developed this model again, kind of just because we had to do something quickly, of working with these independent folks. And they are increasingly becoming more organized in their work. And so the majority of them are charging fees at this point. And although they do all offer a sliding scale, but it's something that we're looking closely at because, again, it's hard enough to access this care, and then you put more financial barriers up, and then often, you know, physicians are charging out of pocket because they can't bill. So it can become, you know, the price tag gets really high really quickly. And then you add in travel and all the associated costs. If you're coming from out of state, it makes it it's cost prohibitive for many people. So it's interesting, right? People should be compensated for this it's very challenging work. You know, it's really doing this bedside attending and shepherding families through this process is intense work. And yet we want to make sure it's available for everyone. So, so we're trying to find a way to get people the access they need and also respect the people that want to help them.
Yeah, it's you know, you said it so well, Amy. It's such a challenge. And, you know, for us in Colorado, we also have not charged for our on the road things where we go all over the state, for our educational things, for when I spend a couple hours mentoring. But I will say that, as with all nonprofits at the moment, we are having a lot of discussion about that because we have to figure out sustainability for the organization. And it's really a hard one for me because I'm like, I don't want to charge to talk to this nurse practitioner. On the other hand, I have a board member who's very wise who says, well, wait a minute, these are really valuable services. And, you know, we have to like buck up, you know, like we probably ought to charge for some of this. We have not gotten that far, but it is definitely on the table that it's something we need to think about. We recently got some really good news with a collaboration with the Colorado Medical Society because we've had a lot of questions about providing continuing education credits, which are very valuable, as most of you know, for all professions, not just physicians. And so they've agreed that they will be our CME provider, basically. You know, those of you who know, it's a lot of headache. So they have agreed to do that, but, you know, they also charge. So we're trying to figure all of that out. But I think it is a very valuable resource, and we hope it also will attract clinicians who are, you know, often, let's face it, practically they need to get their credits. And if we can provide those, that will be a way that we might start charging for that. You can see it's hard for me to get that out of my mouth, but we all have to face up to how our organizations are going to survive in the current environment.
One thing I want to also circle back to, and I know we have so many things to cover and so little time, was each of you touched on this briefly, but how are you all reaching out to diverse populations and demographics in your state? And also I'm also curious, and we're going to bundle this into one, does your state do any reporting? Do you all have an annual statistical report, or what is the reporting that your state does? So 2 parts, how are you reaching diverse populations? We're talking about that with rural care, with funds for meds, with community health workers, but then also what kind of state reporting do you each have?
We have state reporting every 2 years. So our Department of Health reports out the data on that the physicians report in every 2 years. So actually, we're very curious because in January will be the first numbers we see since the state residency requirement fell. We know anecdotally the numbers have increased, both Vermonters and obviously out of state. So that's still happening, and that's still funded by the state to get those numbers out. So we're looking forward to that. Diversity wise, there is a story that I would love to tell because it was such a bright light in the last few months. We got a call from the suicide prevention coordinator for the Veteran Affairs, the Veterans Hospital here in Vermont, asking if we would come and speak to their clinical staff. And so rather than being referred to as assisted suicide, they saw us as part of the suicide prevention team because they had the unfortunate experience of having two elderly vets who both had terminal diagnoses, were under the care of their VA physicians. They both asked about medical aid in dying. Those physicians are restricted from making referrals. Of course, they can't even educate people according to the VA policy. They're not allowed to refer out. And both of those men chose to die by suicide with firearms within the same week, within days of their visits when they were completely left with no information. And so we were so thrilled to go and be a part of their Suicide Prevention Week. And Diana Barnard spoke along with their palliative care director. Standing room only crowd, people on Zoom joining. The medical director was supportive. It was really a very energizing and encouraging day because these vets come from all over the state, from the tiny corners of Vermont to get their care, and the suicide rates of vets above the age of 55 are increasing rather than decreasing. So we're really happy to do that.
Thank you, Amy.
Yeah, in New Mexico, our Department of Health is required to collect data based on a form that they develop that clinicians fill out for every patient that utilizes MAID, and the DOH is required to prepare based on that data an annual report, and that's written into the law.
Yeah. And in Colorado, we do have data. It's annual. Some of you have seen the report. And I have had conversation with the chief statistician for the state. The report is kind of strange. It's helpful, but he adheres strictly to how he has interpreted the confidentiality requirements of the law. So when I say, well, could you tell me who those 95 prescribers are? Or like, could you tell me where they are? No. So there's a lot of inferences. And I just want to know, because I want to help understand where we have the gaps. So that's one area, like I can't get much out of him. And he's sticking to what he thinks is in our law. And the other part of our law that's very strange is the requirement, and the way they do the statistics is how many prescriptions were written. And then they know which of the patients died. But guess what? We don't know if they died from having taken the medication. So we have a lot of inferences there because we know the general statistics, which is that, something on the order of 25 to 30% of patients who are prescribed will not use the medication. So we have to infer kind of what's gone on. We do get pretty detailed information about diagnoses, but as with other states, and we've read about this in the media, and we have to face up to it. We know that not all clinicians know they're supposed to report. I know that sounds strange, but it's true. And we also know that, the department is not doing a lot of reaching out. I can tell you personally, I was goofing up in my first year. I didn't know there was a certain document in addition to what I was submitting. And so I wasn't doing it, but, no one ever called me and said, hey, Barbara, you left out this document you're supposed to send. So that tells me that these are reasonable concerns that others have expressed, that we have these reporting requirements, but that no one is really enforcing them. And so I believe the data is very important. And when I train and talk with clinicians, I do make sure they understand what the reporting requirements are, and that we're trying to keep up our end of the stick by making sure people are doing that. The other question was, I think, about getting to other populations and diversity. We had a big conversation about this at our board strategy meeting a few weeks ago. And, we believe, although I think it's really hard, that we have to have diversity in leadership as a start. And you know what? We all have fallen down on that because it's really difficult. But it's part of our plan for the next year to make sure that as we add board members, that it helps us in diversity on the board and our leadership, because we have deep belief that that will help us in our work in serving more Coloradans and getting out into the state.
Listening to you, Amy, just reminds me of a few things. And in Washington, one of our big challenges is we have so much religious restrictions or in institutions that make it so that people are not able to participate. But the story you told from the VA is so unique because they weren't even able to refer out or give accurate information. And I feel really lucky in Washington that we passed a law in 2020 so that people were required to get accurate information if asked and be able to share it. And I know we have so little time, but I would love if every one of you could just briefly speak to what it looks like to have opt-out or required to refer statutes in your law or not. Because Amy, that's a really impactful story from the VA.
Yeah, so this is an area of our law that I don't think the organization has been able to really focus in on. We know that there, specifically facilities can opt out of people ingesting on their premises. We don't have large Catholic hospitals or hospices, so we don't have that issue, but we do have really inconsistent policies within the hospice agencies. I think we hear from the ground staff that they want this training and they want to support patients, but administrations, even within the same company, but different locations, seem to be setting different policies. So it's a big piece of learning for this coming year for us to really dive in, start really building these relationships. There's, I think, more staff turnover in this world than we would all like to in the hospices. So it's challenging, right? But yeah, so again, yes, we're very supportive. And then I hear after the fact, like, oh, well, we don't let our nurses stay in the room because of liability. And I'm like, oh, sister, we got to talk. But, I got to get them to talk to me. So it's a long-term, it's a long-term project. But it's really important. It's really important.
Julia and Barbara, how about you in Colorado and New Mexico?
You're on mute, Julia.
Thanks, Amy, for your perspective, because I think the more education and outreach we can do, especially to institutions and clinicians, is really critical. And hospice integration is certainly something we're focusing on. We've just met with folks in discussion about long-term care facilities and how varied their response is, and if you're actually living in a place and yet you can't make a choice to end your life using medical aid and dying in that place that is your home, that's a real problem. So there is a steep learning curve despite what may be written, I would say.
And, in Colorado, our law says that if you're not going to provide, you have to help with referral. And, it depends how you interpret that. I interpret that as an active, helpful way. Some of our organizations have taken that as like, nope, we don't do it, forget it, and I'm not going to help you. I do think we've seen improvement in that, in collaboration, and saying, no, I won't do this work, but here's who might help you, and here's how to get records. I think the issue of practicing in what I call restricted settings, having been in both, is a whole day's worth of conversation. And, that has to do with some of the faith-based opt-outs. It has to do with what goes on in federally qualified health centers and how some of them have interpreted that as a complete hard stop no, but how others have actually managed, as with hospices, to figure it out, right? So we have to hope that as this work continues, we can work together with these organizations. The VA in Colorado is an interesting thing. I've not heard I haven't gotten a lot of what I call refugees, like from different organizations. I haven't had a lot of refugees from the VA, which makes me think I should check and find out what's going on. But I think in part, what I see in Colorado is a lot of veterans seem to get their care at the VA and in other places. And so I have this suspicion that they're finding the care because they're already getting care in multiple places. As you know, the veterans will often go to the VA, get what they really need and want there, but they also will make use of community services. And I think this issue about restricted settings and how clinicians can work in those settings effectively on behalf of their patients is a topic for another webinar, right, Casa?
On that, I mean, time has just flown tonight, and I really appreciate the three of you and just listening to you speak. Our staff chat on the side has been blowing up with ideas from each of you and things you've contributed on where we could go next, how we could continue to engage. So thank you to the three of you for spending your evening on the panel with us. We could go on and on, but we're going to have to table it there and for the reason of time. And Daniela, I will pass it back to you to close us out for the evening.
Thank you, everybody. That was a wonderful discussion. And yeah, we're coming up on time. So just some very quick closing remarks. Please bear with me. So once again, thank you for taking the time to spend an evening with us. We could not do what we do without the support of our community members, volunteers, board, and staff. And before we let you go, just one more reminder that we will email the recording of the meeting sometime next week. And this email will also include all the links that we shared today. I believe we're putting some additional links in the chat as I speak. But again, all of those will be emailed to you. Thank you so much. I hope you have a good night, and thank you to our panelists as well.
Thank you all.
Thanks for having us.
Thank you. Goodbye.
Thank you.